Hi everybody, welcome to day 2 of the 2022 Texas EMS Conference. I'm Austin Travis County EMS Captain Krista Stedman. I am joined this morning by our first guest, Dr. Mark Escott, who is our Chief Medical Officer and the Medical Director for Austin Travis County EMS. Dr. Escott, good morning.
Good morning, Krista.
How are you enjoying the conference so far?
It's fantastic.
Well,
what a great thing to host in Austin. Chance to show off our stuff here.
Absolutely.
That we're doing better than anybody else.
We are doing things better than everybody else, aren't we? Let's talk about it. So we wanted to take just a little bit of time to talk with Dr. Escott this morning because we are doing really cool stuff at Austin Travis County EMS. So let's talk a little bit about what goes into our medical practice and how we got where we are and where we're headed.
Well, sure, Krista. You know, we have all the stuff, right? We have all the tools. We have the blood, we have the ultrasound, the vents, the pumps, we have all the things. But I think really what separates us and sets us apart is how we approach EMS in the first place, right? We know that the old school EMS is we send an ambulance, we pick people up, we take them to the hospital, but that's not always what they need. What they need is healthcare, what they need is navigation, what they need is advice, sometimes treatment on scene. And I'm really pleased that our system has been able to mature to really be consistent with the rest of healthcare and not old school EMS.
Awesome. So one of the things that we've talked a lot about is sort of the ever-evolving role of EMS in healthcare. So, you know, we have multiple programs that sort of portray that. We have all of our different provider levels. Let's get a little bit into each of them,
sure,
starting with whatever you want to talk about first.
Sure. You know, our first sort of introduction into this EMS medical practice concept was our provider levels, or our PL levels, which go 1 through 8.
8.
I have to keep thinking because it's changed. I'm 8. But really, the intention behind that is to show our personnel that there is a career ladder for them that involves the clinical medicine piece, PL1 being the first responder or ECA level, all the way up to EMS physician and everything in between. So it is a stepwise progression throughout an EMS career that includes, you know, critical care, advanced practice paramedic. It includes EMS physician assistant or nurse practitioner, what we call a paramedic practitioner, and an EMS physician. All of these things are reasonable things for an EMS person, an EMT or paramedic, to think about and progress towards in the future. All of our docs have done that, right? We started off as EMTs or paramedics, and now we're EMS physicians. There's no reason why we can't embrace that same philosophy for the rest of our personnel.
Excellent.
Well, and you know, let me expand on that a little bit. So some people are going to ask, why do we need, you know, EMS PAs or critical care paramedics or advanced practice paramedics or physicians in the street, right? They have a hard time conceptualizing that because that's not been EMS, right? But when we look at the data from our system as well as across the country, up to 40% of calls involve patients who may not need to go to an ER. They need health care, but sometimes what they need can be done outside of the hospital. And when we look back on our data of calls that our physician assistants or physicians have responded to, more than 50% of them have been able to be dispositioned without going to an ER. That's a huge time savings for our EMS system. It's a huge amount of returned work hours to our ambulances, and it's a huge savings not only for our patients, but for the healthcare system in general. So it's a win-win.
Absolutely. You know, you talked a little bit about data. I want to dive a little bit more into that because I do know that we're doing a lot more with the data that we're collecting, especially when it comes to your office. So can you just sort of outline, there's a couple of new positions in your office that have been filled. What are they doing with the data that we get, and what are we going to turn around then and do with that?
Sure. So we have a new data manager, we have a new researcher, we have 2 new quality improvement coordinators. And the concept is to gather our data and to process it in a way which is more useful for us as a system and that makes sense for our community. So the intention is to create outcomes dashboards, cardiac arrest, trauma, overdose, STEMI, stroke, just to name a few, because it's important that we move away from this focus that we've had ever since I've been in EMS around response times as a measure of equity and quality and move towards outcomes, right? Outcomes are really what you want to measure, but we haven't had the technology in the past to do it. Now with our ESO medical record system and the outcomes dashboard and some of the databases that we have access to, it allows us to complete the picture, to show the call from 911 call to disposition from the hospital, which allows us to generate these dashboards. So it's really exciting. It also, I think, will better inform our approach to equity in our system.
So how are we going to use that data to more equitably deploy resources throughout our system so that we are equitably serving the residents of Austin and Travis County and the visitors?
Yeah, that's a great question. And I think one a lot of EMS systems have, right? You know, when they think equity in response time. So if my response times are the same in various districts in the community that I serve, that's equitable. Well,
is it?
It's not, right? When we talk about equity, we need to assess equity of outcomes. Because we know that there are areas of our community that don't have access to medical care, that have significantly higher rates of, you know, underlying causes, hypertension, diabetes, heart disease.
Sure.
So in those communities, an equitable response time is not equitable outcomes, right? Because they have higher rates of cardiac arrest, for instance. They have worse rates of CPR, worse rates of AED use, and of course worse outcomes. So when we assess outcomes, it better informs our decision making on where we put stations and resources, not only EMS system, but also public health and community health, so that ultimately we can create equitable outcomes across our community.
Awesome, love it. Well, that is all we have with Dr. Escott this morning. Thank you for joining me, Dr. Escott. It's always a pleasure.
Great to see you.
Stick with us, and we will be back with more chats throughout the rest of the day today.